And I'll try to, we're getting ready for the reception, so I'm standing between everybody and drinks, so I'll try to make this as quick as possible. But I think it was an interesting topic that was assigned to me, and I'd like to talk to you. I think it's a great time to look at this because this year is the 30th anniversary of the introduction of the Mays procedure, this is Barnes Jewish Hospital in St. Louis, where Jim performed the first Mays procedure exactly 30 years ago, and he's given you that history. But I think it's interesting to look back. It's a good time to look back that over the last 3 decades, I really think while we don't have a lot of prospective randomized trials, there really is a great body of evidence suggesting that surgical ablation is efficacious. And in many ways, it was the efficacy of the Mays procedure that led to the development of the catheter ablation techniques we've heard quite a bit about. I'm going to confine my remarks both because of time and also because almost all the available really late results are with the Mays procedure, and we'll just really talk about what is the benefit of that. But I think we've seen earlier today there's certainly other very promising and particularly hybrid ablation, which will probably be able to come close to some of this. Despite the paucity of large randomized trials, I would say it's not fair to conclude we don't have any evidence. We just don't have that evidence. But as many surgeons know, it's very difficult to conduct surgical randomized trials. I think we need to do them, but and we're at a point where I think we can do, but there's a lot of challenges to them, and I'll show you some of those. So what are the benefits of surgical ablation I'd like to talk to? And we'll start with restoration of sinus rhythm because that's where we have the most evidence. And probably we have much better evidence in the concomitant ablation, which still is the great majority of surgical ablation. In fact, in the US, in the last survey, 95% of all ablation is performed in the concomitant session. But we do have 30 years experience in St. Louis, and I'll show you our results and some of others with standalone ablation. This is the report. Jim showed this, so I can go pretty quickly, but when I got to St. Louis, we looked at Jim's first 200 patients who had the cut and sew. We call it cut and sew, but it was, all these patients, the great majority, there was a few cryo procedures in, but most of them were cut and sew. And this was the long-term efficacy, and I'll have to say there's some great points that have been made earlier today, but this is clearly late recurrence of symptomatic atrial fibrillation, and back in those days, virtually very few of these patients had any type of prolonged monitoring. But still, it's pretty impressive. This is a group of 112 patients who we had over 90% follow-up, and at a mean follow-up of 6 years, 80% were free from AFib. According to them, they were asymptomatic, and another 16% were free on antiarrhythmic drugs, leaving only 4% of the patients. It's pretty impressive when you look at it, even if it's not what we would consider the right follow-up in terms of our present guidelines. It makes a good point that definitely these lesions did something, and for the great majority of patients out, and those results, and Jim showed the graph, and I took it out this time, but they held out to over 10 years. We saw just about the same. In 10 years, it was still 92% of patients were free of symptomatic atrial fibrillation. In 2002, Jim said, we modified it to basically replace most of the incisions with ablation lines, and I talked to you about bipolar RF and cryo we used around the valve annuli because you can't get the clamps down there. And both, basically, these were the two energy sources that we found were the most reliable in the experimental lab. And we introduced this procedure, and I'll show you the results with that, and we have now over 15 years experience with that. But we first published, looked at 212 consecutive lone patients and compared the results we had with ablation-assisted Mays 4 to the cut and sew Mays 3, and you can see the patient populations. The average AFib duration in both groups was over 7 years, which is not your typical group. The mean left atrial diameter was over 5 centimeters in both group, and you can see the change in time in the present era. About 40% of the patients we did lone mazes, that number is now up to 75%. had a previous ablation. But this looked at our whole experience. You can see most of the patients were as opposed to in the original maze, most of the patients, which is interesting, because this predated really catheter ablation in many ways. 63% are paroxysmal, but now only 30%. And that number in the last 5 years has gone down to 10%. So surgical ablation has changed. But despite dealing with what would be a much more complicated group of patients, you can see the results are the same. As Jim said, we took the time to do the operation and cut it basically in a third, and also cut the major complication rate down significantly, but we're able to do that without any difference in our freedom from AF and antiarrhythmics off drugs. Was really over 80% at last follow-up in both groups, despite the fact that in this group, the majority of patients had prolonged monitoring, I think at 75%. Clearly not as long follow-up, but I'll show you now, we now have good five-year follow-up, both from our center and from NIV's center on surgical ablation, which would, I think, testify to the durability of these energy sources. This is a paper we just published looking at 576 consecutive patients. Again, though most of these are about 3/4 were concomitant, but just to look at the durability of this lesion set over time. But all were followed. Failure was defined per the present guidelines as anything more than 30 seconds of AFib, atrial flutter, or atrial tachycardia. And this is single procedure. We considered any intervention after 3 months, including cardioversion, and certainly any type of repeat ablation, to be a permanent failure. So this was very strictly defined failure, and this is single procedure success rate, and you can see even out at 5 years, and we had well over 100 patients now out at 5 years with a 78% success. If you looked at our symptomatic success, it's about what the original maze was, but you can see that this is still durable, though it's interesting that there appears to be a slow decrement in success, but part of the thing is with prolonged monitoring, it's easy to pick up short. The average AFib burden in the failures was less than 0.1%. It was very unusual to have a failure, and we've seen very few failures where they go back into AFib. The interesting thing about the maze lesion set, and this is the data from the same trial, is that the success rate at 5 years was no different for paroxysmal versus, and virtually you can see our average duration of AFib was is still up over around 7 years. This is virtually all long-standing persistent, and you can see with a single procedure to have 78% success at 5 years, I think, shows that durable lesions, I think, can give you good late success. This is data from NIV, who really does most of his patients are cryo, though it's a kind of a combination, and he looked at over 780 patients, and really very similar results of maintaining sinus rhythm. And him out hit 5 years, he had 85% sinus rhythm. You can see he also has over 100 patients, and about 70%, very similar to our numbers, were free off antiarrhythmic drugs. So I think this is a very durable, if you use the right energy source, this lesion set seems to give very high success rates. And I would say it compares very favorably, and we've seen this study with the results of a single catheter ablation. Now, technology is changing, but this is long-standing persistent. You can see long-standing persistent, we had 78% at 5 years, and NIV had exactly the same. And that now is our combined series has over 1,400 consecutive patients, all have been followed in a longitudinal database. I would note that we have followed all of our patients since the first, the first patient actually, the interesting thing is we were about to have a big press release with the first maze, and at 21 years he recurred. We were going to celebrate the 20th anniversary of the maze. So it's interesting, if you follow them long enough, it's interesting. And we have people that we followed out 10, 20 years. It's interesting, and that might be something we can publish later. They do continue to see a decrement. So, but what about, most surgical ablation is performed in patients with concomitant disease, and by far the majority of surgical ablation in the world, and particularly in Asia, is in patients referred for mitral valve surgery. And now I want to show this because this is the one area we actually have a lot of randomized trials. So how effective it? Well, here is the first 7 randomized trials. You can see compared to the EP literature, it's pretty pitiful, the low number of patients, but they were all consistent in that every randomized trial showed a significantly better freedom from AFib with surgical ablation. So we do have randomized evidence that the ablation is very good at restoring sinus rhythm. You can see is one of the things that still is a problem in surgery is that the results were a little bit, for surgery, were quite variable. But for instance, this report used a unipolar pen, which in the research lab, ablation devices do make a difference, and if you use an ineffective device, you're just not going to get, you just can't do, the lesions have to be, you have to have some lesion integrity to actually tell if you device, so there's an interplay there. But I think very good results, and this is, Jim showed this study. I think it's an underpowered study, and it is a good, if you talked a lot of centers, we actually refused to participate in it because we thought after 25 years to randomize patients to nothing. We did not have equipoise to randomize a mitral valve patient not to be ablated. But they decided to do it again after, there was actually, by this point, there were 8 randomized studies. There was no question that every single one had shown a benefit to ablation, and as the 9th randomized study, they showed it. Also, Jim already went through a lot of the weaknesses, but again, it showed, there's no question, compared to doing nothing in our most common patient subset, this is better. So it also, I think this is one, we always have a question is, does ablation add to mortality or morbidity? And this study was 260 randomized patients to ablation or no ablation. There was no difference at all between the groups in major cardiac or cerebrovascular events, readmission or mortality rates. Now there was a difference in pacemaker implantation, and that is a topic of another talk, but most patients would easily trade AFib and anticoagulation for a dual chamber pacemaker, but their rates were a little high, but most of these were mitral patients, and over half their pacemakers went in for complete heart block, which is really impossible to get with a maze. You cannot get complete heart block. It had to be due to the mitral procedure, and why they had such a high degree of heart block, complete heart block, I can't tell you. How about prevention of stroke? And I won't go a lot into that now. Everything else now is that I'm going to show you is we have no randomized evidence. So you'll just have to take, what we do have is a lot of experience and a lot of patients that have been followed, and you'll just have to say, while low level, I think it presents a good case, and it's an area that we're going to have to look at some randomized study. I would say with the maze procedure, we amputated the appendage or oversewed it in every case. I would have to say that the 100% way, which was the original part, the way we do it when we were doing sternotomies, which we don't do anymore, is we cut the appendage off, and that's really 100% effective. We've had much better results in oversewing, and we've looked, our recannulation rate is less than 10%. But, I think, that was done, and Jim reported the first, which was a very low incidence, his 0.1% per year after a maze in terms of recurrent stroke. Now, this was just theoretical recurrence rates here based, so you just have to take this. But whatever you want, you can argue about what these rates should be, but this was a very low incidence of stroke, and this was in his really entire series of mazes. This has been verified by other investigators. This is a really interesting study. It doesn't get quoted much, but Ko Bando from the National Cardiovascular Institute in Japan really did a very large trial. It's again non-randomized, but he looked at 363 patients who either had a maze or didn't, who were coming to the operating room for mitral valve repair, and followed them for over 4 years. But the freedom from stroke was really dramatic if you got the maze. Freedom from stroke 98% versus 83%. Again, having an incidence very similar to what Jim initially reported. This is our report, which we published in 2013, 433 patients followed for over 6.5 years. We only saw 6 neurologic events for an annual stroke rate of 0.2%. And there was no association to CHAD score, I would have to say, and there was no association either to warfarin use, the only association we found that if you had a prior stroke, and now we don't recommend in this group to ever discontinue anticoagulation, that seemed to be where the recurrent strokes were. But we've had a policy at our institution of discontinuing Coumadin at 3 months as long as you were out of AFib and had good atrial emptying, and we ignored CHADS score. We're now flying in the face of the present guidelines, but we have our own data, so it doesn't appear that we haven't changed our policy yet, just because, I mean, it's one advantage of following your patients. And we've already talked about the exclusion technology, so I'll just go with that, and that's been already talked about. But I think that is now even a simpler way and perhaps a better way of excluding the appendage in that. But there clearly appears to be a benefit of stroke reduction following a maze, albeit we don't have good randomized trials. How about improved quality of life? Again, we don't have any randomized trials, but we have some interesting reports of looking at quality of life, and probably one of the best ones, it's still not a huge number of patients, was from Sweden in 2000, and they looked at quality of life both before and after a maze. And this is at baseline compared, this was the AFib patients compared to the Swedish normal population. And following the procedure, you really saw no difference between normal and abnormal patients. This was only about 48 patients, but I think it does show quality of life. And both NIV and our group, this is our group in 68 consecutive patients, and showed that we just normalized the normal population to 50, and really afterwards, and this was performed at a year, we had excellent quality of life, and other, at least several other groups around the world have shown similar. How about improved left ventricular function? And because of time, I took some slides out. There's been actually interesting, but we have a manuscript we just submitted in this, and I think it gets back. Harry has mentioned tachycardia-induced cardiomyopathy. We think that's a real good indication right now. One of the things that, at least in our center, we will sometimes go right to a minimally invasive maze, only because we've had very durable results with that. And it really seems to have a pretty big, we looked at 35 patients who were referred to us just with low atrial fibrillation and ejection fractions less than 40%. And the post-operative EF improved to 54% by echoes. We perform all our echoes post-op between 1 and 3 months. By a year, that had actually gotten up over 60%. But this is, I think, is another advantage of both catheter and surgical ablation in patients with tachycardia-induced cardiomyopathy. It's interesting, this is the actual data, but the only patient that went down in this group of over 30 patients was the one patient who remained in AFib. But you can see pretty dramatic. This patient here was on the transplant list at a university center south of ours, and a month after the maze had an ejection fraction, went from 10% up to over 50% in a month. I mean, it's a pretty dramatic resolution, and if you get the diagnosis right, and that's a subject of another talk, you have to be careful that you're not dealing with patients who have other types of cardiomyopathy. But and then finally, improved long-term survival, and this is an area where we really can't make any comments. I would say it's an area we do need randomized trials. I would say that, you know, as opposed to the in your electrophysiology community, one of the problems of doing long-term trials is the lack of funding, both by our government, and we don't have the different industry support is not at the level that I think you have in cardiology. It's an excuse, I know, but it's been one of the reasons. It's been very hard, and they're expensive. You know, this was another trial. I'll come back to this one from Japan, which had a large number of patients, but they did show freedom from cardiac death was very significant at about 4-year follow-up. There's been a study, Jim showed it, so I took the slide out. The group at Northwestern showed a survival benefit, and we have this now in press. We took 242 propensity matched pairs, and this was done propensity matching for about 50 different variables that we thought might impact survival, and matched 342 patients with AFib who had a maze versus who just underwent cardiac surgery and no maze. There was no, in this, what is a pretty large propensity match group, no difference in 30-day mortality or complication rates, but we did see significantly better survival in the Maze group, and this is survival out now to 10 years with a 95% confidence intervals, and we have still quite a number of patients at even 10 years, but you can see at 6 years we have almost 100 patients still, and you can see the lines really separate, and it's interesting. I think in the modern era where you don't have much procedural mortality, these curves act like you would expect, and that they continue seeming to diverge, which would suggest there is a long-term benefit, which we intuitively know is obvious, but is hard to prove, that there has to be a benefit of staying in sinus rhythm and not having AFib and not having probably your appendage. But this is another bit of evidence. So in summary, and to get everybody to the cocktail break on time, I'll just say I think despite the lack of randomized trials, except for point number 1, which I think there's no question that surgical ablation, particularly concomitant ablation, is a major benefit in restoring sinus rhythm. We do have 30 years of experience and longitudinally followed hundreds of patients consecutively, which suggests that we do prevent stroke, we do improve quality of life. In patients with tachycardia-induced cardiomyopathy, we improve left ventricular function, and we clearly, I think, we'll be able to show, if we can ever do this, a randomized study that would improve survival. It's very hard at this point, like in our center, to prove that point, to randomize patients that we could potentially cure with this data. I mean, it becomes the fact that, do you have equipoise to prove this point? Am I going to really put someone at risk in terms of both having a stroke? I mean, it's very hard right now to have equipoise. I would have to say, in the mitral population, I clearly do not, but I might in a CABG population, but I do think we do need good prospective randomized trials, but I think we can't. Big prospective multi-center data collection, I think, has a value, and I think we have to better define the magnitude of these benefits if we want to continue to play a role, particularly in the area of lone AFib. Thank you.
Excellent overview, Ralph. Thanks very much. There must be questions from the floor. If not, I'm going to ask you, you see, you showed quality of life data, and indeed, after surgery, these studies showed a significant improvement. I think that that's an important observation, because even non-randomized, that's true. That's what it is, because it's before and after. And what is now really, why are these studies so positive on quality of life? What do you think is the main driver for that?
Well, I think, having been doing this for, why does their quality of life get better? First of all, you have to, these were all standalone. I think the first thing is we're dealing with of the iceberg of AFib, we're dealing at the very top of that tip of the iceberg, as many of you know. I mean, the patients, when they finally have come for surgery, have often failed other procedures and really have symptomatic AFib. So we're dealing with the extremely symptomatic patients. And I think in those patients, restoring sinus rhythm, I mean, I think all of us know, it's amazing. I mean, being a cardiac surgeon is great because patients are really grateful for everything you do, but it's always surprising me how much, we tend to, a lot of the internists are always just rate controlling people. But it's amazing in patients who are really symptomatic. Once you get rid of it, they'll all say, I feel like you've given me my life back. They're completely debilitated. I think that's why the surgical series, they're really extremely symptomatic people. Now, they've also gone through what in a lot of these studies was a pretty invasive procedure, so I'm sure they want to feel better after that also, so there's a bit of a placebo effect. But I think it's really true, and I have to say these patients are extremely grateful, and I think another thing to remember, probably the most grateful time is when you tell them they don't have to take, well, now with the novel anticoagulant, it's not so bad, but when you could tell a patient you don't have to take warfarin anymore, that was huge. And even now, I mean, patients have, I think even with the novel anticoagulants, it's a great thing. And I think it's both that they tend to have sinus rhythm and they get off anticoagulation, which is a big deal.
So and the same is true we know this also from the early days where we did AV ablation, give a pacemaker, was done in the highly symptomatic patients. They improved. So I think you're completely right. So it's that they are symptomatic. Now the very difficult group of patients is the one with the tachycardiomyopathy. Because the funny thing with tachycardiomyopathy is that they are very frequently, even with low ejection fraction, asymptomatic. The doctor's usually more worried than the patient. And that makes these patients come to ablations. Now, my question to you is that you show this series where everybody improved, except for this one patient who remained in AF. What does the cardiologist tell you why you should ablate surgically a low ejection fraction atrial fibrillation patient? What does he tell you? How does the cardiologist know that the ablation is going to improve the patient?
So that's a tough question because I haven't really surveyed the cardiology. I think tachycardia-induced cardiomyopathy is a well-defined entity. It's interesting because one of those patients, he was in the room coming for surgical ablation, and the other room was a patient coming for a VAD, and his EF was, when you compared them to the patient going for a VAD, had actually quite a bit better ventricular function. It's amazing how bad they can get. I mean, I think, but it is also, both in experimental studies and, we had developed when I was at Duke a model of this tachycardia-induced cardiomyopathy in dogs, just atrial tachycardia. And it's amazing how quickly the animals, and also people, I mean, they're almost better before they leave the hospital. They're dramatically improved. I think that's a whole nother issue. We're a big heart failure center, so I think it's very important to make sure that it is a tachycardia-induced cardiomyopathy, both with, prolonged monitoring to make sure they're having tachycardia, and also we get MRIs on everybody to make sure, and in the real severe patients, we've even done endocardial biopsies to make sure we're not missing something. But don't you think that's true in the catheter ablation? If you pick the right patient, they have a dramatic improvement.
Yes, of course, sure. They improve if you're successful with the ablation. We mentioned already you really must be sure that AF stays away, because if it recurs, then they come back with low ejection fraction again. I think this point now also very well illustrates the need for AF heart teams, because if they put a patient on your desk and you're happy, I can do a surgery on a patient with AF, you still must be sure that the patient is going to improve, because you think it's easy for us to diagnose that patient, but that's not the case. It's a very tachycardiomyopathy is a very difficult diagnosis. In fact, to speak the truth, we just try the ablation. If it improves, we know that's the diagnosis. so if there's no more questions, then we thank you very much for this excellent presentation. Thank you very much, Ralph.